In the trenches today, we're going to talk about hemolytic anemia. My student requested autoimmune hemolytic anemia. I'm going to try and cover immune and non-immune mediated. Some pearls. So when you're talking about anemia, you have three major mechanisms. You have blood loss, you have hemolysis or red cell destruction, and you have a bone marrow problem. You at least have to have one of these three mechanisms. Okay, now if you bleed enough, you'll become iron deficient, then it's a bone marrow problem. You hemolyze enough, you'll become iron deficient and folate deficient, then it's a bone marrow problem. So it could be multifactorial. Today we're going to talk about hemolysis. So, when you suspect hemolysis, so you're evaluating anemia, and one thing you're going to need to get in your evaluation is a reticulocyte count. These are the young, immature cells, 0.5 to 1%, to 1.5%. About 1% of your cells should be reticulocytes. They're larger and they have a purplish, bluish discoloration called polychromasia. Okay, if you're hemolyzing, your retic count should be elevated unless you're not compensating. Okay, the same with blood loss. With a bone marrow problem, it'll be low. Okay, and if you have a lot of retics, your MCV could be elevated because it's the average of all the size of all your blood cells. So a high MCV doesn't mean it's just vitamin B12 or folate deficiency. Anyway, if you suspect hemolysis, obviously you wouldn't do a history and physical exam. And then you need to kind of assess it. And you can really divide it into two categories, immune and non-immune. So, immune-related hemolytic anemia is there's some antibody involved that's causing destruction of the red cells. And the classic hallmark you would see in a peripheral smear is a microspherocyte. It kind of looks like this. Normally a red cell is a biconcave disc with about 1/3 central pallid. There's no central pallid here. This is the hallmark. And then you need to think what's causing it. Okay, now you can divide it into two categories, congenital and acquired. Congenital, they often have a history of this. The most well-known is sickle cell. And thalassemia of hemolysis, it's intracellular. But here you can think of abnormalities on the membrane, which would be hereditary spherocytosis, membrane hereditary spherocytosis, elliptocytosis, stomatitis. These are very rare, okay? Or an enzyme deficiency in the red cell. Most common being G6PD deficiency. Next most common, pyruvate kinase. Okay, G6PD deficiency, you could see. That and about 12% of African American men are positive for that, and if they're brought under the right stress, it could potentially precipitate that. Okay, then you have the acquired causes, and really you can divide this into warm and cold agglutinin. So warm antibodies at normal temperature, you have an IgG. Binds the red cell, and the macrophages in the RES system kind of take a snip out of the red cell, and what you have remaining is the spherocyte, and it's autoimmune and idiopathic warm agglutinins is the prototypical disease. You can see that type of physiology with other syndromes like lymphoproliferative neoplasms, non-Hodgkin's lymphoma, and CLL, and connective tissue diseases like lupus. Same thing, autoimmune. Okay, cold agglutinin, here you have complements involved. Something triggers this, and this could be idiopathic also. And it causes intravascular hemolysis. It triggers destruction of the red cells. Here, it precipitates in the cold, and it's either and this is IgM mediated. Okay, this is IgG mediated. Cold agglutinins here. Okay, if it's acquired, sometimes you could see it with lymphoproliferative neoplasms. You can also see it with mycoplasma infections and Epstein-Barr virus infections. Then the other things you can think of, once in a while drugs can do it, and we classically learn 4 mechanisms: the haptin, the autoantibody, the innocent bystander, abnormal red cell membrane. That's kind of not, the most common antibiotics that do that are piperacillin and ceftriaxone. The other thing that can cause immune-mediated hemolysis is a transfusion reaction. Someone gets a blood transfusion. And then there are a bunch of miscellaneous causes: paroxysmal nocturnal hemoglobinuria, and paroxysmal cold hemoglobinuria. These are unusual things, and I don't want to spend a lot of time, but immune-mediated, you normally get a Coombs test. You'd see peripheral spherocytes on the blood smear. You want to make sure they don't have a lipoproliferative disorder, or they don't have a connective tissue disorder like lupus. Cold agglutinin, you're going to get a cold agglutinin test and then take it from there. Now, non-immune, with this you think of normally the thrombotic microangiopathies. And here you have the phenomenon of MAHA, microangiopathic hemolytic anemia, where the red cells actually get destroyed intravascularly. And what you see on the peripheral smear is something called a schistocyte, or a helmet cell. It's like a red cell fragment. Okay, the prototypical diseases are TTP, hemolytic uremic syndrome, and DIC. You can also see it with the HELP syndrome in obstetrics patients. And then you could see macro, and you could also see it with hypertensive emergency, or a scleroderma crisis, where the blood pressure is so high that the cells get sheared rather. Or you can see it with heart valve hemolysis, with prosthetic heart valves, classically the older heart valves, and classically with the aortic valve. That's microangiopathic, and with the valve, macroangiopathic hemolysis, and this is non-immune. Theoretically, if you want to have a third category, hypersplenism, where you have the spleen just sequester red cells. But this is a short talk on the approach to hemolysis. It's helpful if you can look at the peripheral smear and then get the appropriate test. If it's autoimmune, usually you're going to treat with steroids or gamma globulin. Steroids are basically will block the FAB, will block the receptors on the macrophages in the RES system and prevent uptake, and they will also decrease antibody formation, IgG, as will gamma globulin. If that doesn't work, then you have to think of other options like Rituxan. Steroids don't work as well in cold agglutinin hemolytic anemia. And with that, we're going to stop. Quick talk on hemolytic anemia.